our research, as most research in the endeavor of human disease, is seldom done in a vacuum. And in fact, one of the benefits of our association with the CFIDS Association is that they are very masterful at coordinating our efforts with those of others, and as this flow diagram shows, we actually work with several other local investigators, each of whom is very experienced and well published in the area of chronic fatigue. Many of you may know the name Benjamin Nadelson, and Dr. Nadelson is one of our consultants who assists in our evaluation of subjects to assure ourselves that the subjects that we are enrolling in fact have chronic fatigue syndrome and not other mitigating factors which may appear to be chronic fatigue, but in fact these patients may not have chronic fatigue syndrome. In addition to my working with Dr. Stewart, Julian Stewart, we also are in close collaboration with Dr. Dikoma Shungu, who is at Cornell University Medical College, and his colleague Sanjay Matthew, who is at Columbia University. They are doing some very, very interesting brain scan studies using sophisticated MRI equipment to look at local brain metabolism and to see whether or not folks with chronic fatigue syndrome utilize nutrients in their brain differently than non-chronic fatigue syndrome individuals. We all work, that is, that if Dr. Shungu gets subjects directly from outside references or through Dr. Nadelson, they eventually wind up in our laboratory. Conversely, we refer patients to Dr. Shungu, and we've had a lot of success in sharing of patients, and hopefully the coordination of our studies along with those of Dr. Shungu once again will add another piece to that jigsaw puzzle. One of the things that we do, and I'll talk more about it, is we do tilt table testing, which allows us to impose an orthostatic challenge to see what the cardiovascular response is to that challenge. And I'll go on to talk a bit more about it, but what we basically do is we segregate our study population into those that have chronic fatigue syndrome with POTS, or NMH, neurally mediated hypotension, versus those patients with chronic fatigue without the orthostatic challenge. This is what appeared in my grant proposal, which is what we're working to achieve. We haven't quite achieved full enrollment, but we're basically looking to recruit subjects 15 to 29 years of age. Actually, we've recently increased this. It's actually 15 to 39 years of age. We expect to enroll 15 controls, 15 subjects with chronic fatigue syndrome alone, and another 15 with chronic fatigue syndrome and POTS. I spoke before about the methods that we employ, and there are lots of them. Essentially, study subjects, be they control or chronic fatigue subjects, come into our laboratory, and they spend the better part of a day because we hook them up, so to speak, and we put all sorts of gadgets and gizmos on them that allow us to continuously monitor and record their heart rate, their blood pressure, their respiratory volume, their rate of respiration, and very importantly, their end tidal carbon dioxide. Now, as all of you know, we breathe in oxygen, and the waste product of our metabolism is carbon dioxide. And I'll speak a bit more about carbon dioxide later, but carbon dioxide is a very important regulator of many body functions, including brain blood flow. In addition, we have a rather sophisticated method of changing the distribution of fluids within the body, predicated upon the fact that our blood contains ions, and we can actually, through something that's referred to as impedance measurements, look at the change in resistance across different body segments, thus allowing us to make estimations of changes in the distribution of body fluids. In addition, as I mentioned earlier, because the skin is a major repository of fluids, we use skin, we make continuous measurements of skin blood flow by laser Doppler flow measurements, which, as I'll show you later, are non-invasive. They involve placing small laser lights on the surface of the skin, sort of like the similar to the oximeter, that little finger gizmo that people have put on if they're unlucky enough to have to go to the hospital, where it measures degree of blood oxygenation. This is similar. There's a small laser that sits on the surface of the skin. It shines a laser light through the skin. The laser light bounces off of blood flows that are blood cells rather that are flowing by, and the reflected light is measured and gives us a good index of the amount of blood that's flowing in a small area of skin. Much the same way that we can challenge the heart by putting folks on a tilt table and tilting them, we also like to challenge the skin, and we can do so in one of two simple ways, either by heating the skin that the laser is looking at, or providing local drugs to the skin area that the laser is again looking at. And I'll clarify that by showing you some slides a little bit later. Insofar as the blood, the brain blood flow measurements that I mentioned earlier, we use transcranial Doppler measurements, which, as I'm sure everybody knows, is a non-invasive way of measuring brain blood flow in selected areas of the brain, and I'll show you a diagram of just what we look at. And from those measurements, we can do calculations to look at various factors, among them are flow dynamics and coherence, and the issue of coherence, that is the relationship between brain blood flow and, for instance, blood pressure is very, very interesting, and we've shown some alterations in certain subpopulations between control or normal individuals and people who are orthostatically challenged, and I'll speak a bit more about that in detail later. In addition, it's been recently published and has been our experience, and I'll show some slides to substantiate that in our population, that many individuals who are either orthostatically challenged or have symptoms of chronic fatigue, in fact, have been shown to have decreased blood volume. We previously measured blood volume in research subjects using an experimental method with a substance called indocyanine green. We no longer use that because there's been the advent recently of a radioactively tagged determination of blood volume, which is very sensitive. It actually involves minimal, very, very low levels of radiation, and gives us a very good indication of blood volume. So those are some of the measurements that we employ. And what we do is we use the diagnostic criteria for chronic fatigue along the lines of those described by Fukuda in 1994. And any of you out there with chronic fatigue recognize some of these. This certainly is not a listing of all of the criteria, but among the more frequently reported is impairment of memory or concentration, the so-called brain fogging, mental clouding or impairment, muscle pain, or focal joint pain, headaches, none or unrefreshing sleep, post-exertional malaise lasting for more than 24 hours, and paramount in all of these is fatigue. Now, in our patients, recently, 80 to 90% of the subjects that were initially referred to us for chronic fatigue syndrome turn out to have POTS, or postural tachycardia syndrome, as well.